Very good. All right, so we're going to talk about the aorta. So some of this we've already kind of covered in vascular, particularly the dissection portion of it. But we'll go a little bit more in depth because for us, we actually use a slightly different classification for dissections. We also, as well as the Stanford, we also do the DeBakey classification for aortic aneurysms. But just to start off, there are 6 segments. Aorta pertains to us with echocardiogram that we're focused on. So the aorta will begin at the annulus. So our annulus, is our the root where it connects to the heart, and it's that anchor for the aortic valve. So the first segment is going to be our annulus. And the normal diameter for the annulus is, I'm going to do it in centimeters. So it's 2 to 3 centimeters. 2 to 3 centimeters. And then as we move up the aorta, the next segment is going to be our sinuses of Valsalva. And this is going to have a wider diameter. So this is going to be 2.9 centimeters to 4.5 centimeters. That's 2.9 to 4.5. As we continue moving up, the next segment just above the sinuses is going to be our sinotubular junction. That's the sinotubular junction. This is where the aorta is starting to taper and take on more of that uniform diameter, but it's still a little bit wider. So this now has a diameter of 2.2 centimeters to 3.6 centimeters. So this is 2.2. Right? Yeah, 2.2 to 3.6. As we continue up the aorta, we get into the ascending tubular aorta. We have ascending tubular aorta. So the ascending tubular aorta is the whole section from the sinotubular junction where the diameter becomes uniform again, going up to that arch. So this has now a diameter of 2 centimeters to 3.6. The next segment we get into is our aortic arch. And And then this same has the same diameter as the ascending tubal aorta, 2 to 3.6. 2 centimeters, 3.6. Right. And as we continue past the arch, the last segment is going to be our descending thoracic aorta. And diameter of 2 centimeters to 3.6. So if we have to label some more structures on here, if we're doing our suprasternal notch, you'll potentially see a little, oval vessel here sitting in the arch. So this is actually going to be our right pulmonary artery. That's right. Pulmonary artery. We're labeling our branches off the arch. We have our left subclavian, left common carotid artery, CCA, and brachiocephalic or nominate. Nominate. There actually is another view where we can get a good look at the aorta as well in our apical 2 chamber. Apical 2. You can actually see the descending thoracic aorta visualized over here. So in our apical 2, we can see our descending thoracic aorta. I'm doing it on that side. Alrighty. So only about 4 to 8 centimeters of ascending aorta, arch, and descending aorta are visualized on echo. Ascending AO, arch, and descending aorta. Seen with echo. So we know that our parasternal long axis view is best for viewing aortic root. So we know that the root includes the annulus, the sinotubular junction, as well as the sinuses of Valsalva. Carcinoma, best for evaluating the root and ascending aorta. Suprasternal notch is best for assessing the arch, as well as short segment of the descending aorta. Suprasternal notch or arch, descending aorta. But if you really want to get a good look at everything, we'll do a TEE. It provides a broader window for assessing the aorta, and we can image the ascending, the arch, as well as the descending aorta. TEE.
Dan, you said the aortic root is the annulus, the sinotubular junction, and the sinus Valsalva. Okay,
Yes,
cool.
all three segments make up the root. Yep. We will assess all segments. Okay, start talking about now aortic aneurysms. An aneurysm can occur anywhere along the aorta. So we can have aneurysm anywhere along the length of the aorta. Typically more common at the root of the aorta in terms of our ultrasound examinations, but it's a aneurysm. So dilatation. Occur anywhere. Aneurysm is defined as an enlargement to more than 1.5 times normal dimension. So defined as dilatation greater than 1.5 times normal diameter. So dilatation in the aorta can be isolated or it can be due to other cardiac diseases such as hypertension or aortic valve disease. Conditions can be isolated or due to other cardiac diseases. tension or aortic valve disease. There's a disease called annulo-aortic ectasia. This is an idiopathic dilatation and tortuosity of the aorta. Annulo- aortic ectasia. Idiopathic. Dilatation. Tortuosity.
So what the annulo aortic ectasia, what is that, like another type of aneurysm or?
So this is a disease that can cause an aneurysmal aorta.
Oh, okay. Thank you.
So it's idiopathic. So it's a condition where you get this unknown, well, it's not really a disease. It's a condition. When I say condition, not a disease, a condition where you have a dilated tortuous aorta for unknown reasons. So primary aortic dilatation occurs with cystic medial necrosis. So primary aortic dilatation occurs cystic medial necrosis. What is also seen with other connective tissue disorders.
Would those be like the Marfans and the Ehlers-Danlos?
Yep. So cystic medial necrosis is it's the breaking down of that muscular layer of the vessel that allows that dilatation to start occurring. So this process results in the weakening of the medial layers with the subsequent dilatation and aneurysmal formation of the aorta. could say process involves weakening of medial layers vessel. Which results in aneurysm formation. So like Morgan was saying, that's, the connective tissue diseases are going to be our Marfan syndrome and our Ehlers-Danlos syndrome. Secondary dilatation occurs due to volume and pressure overload states. So secondary dilatation. Occurs due to pressure and volume overload states. So our primary aneurysm, when we're talking about Marfan syndrome, is going to more likely involve the sinuses and the ascending aorta. So we're talking about, an aneurysm occurring, at the level of the sinuses going up in that proximal ascending aorta. So when we talk about secondary dilatation occurring as due to pressure and volume overload states, an example of that could be a post-stenotic dilatation of the aortic valve. So we have post-stenotic dilatation of the aortic valve. So if we have a severely stenotic aortic valve, on the other side of that valve, we're going to have dilatation. We'll see this. You'll see this in pretty much any stenotic lesion when we're looking at the arteries. When you get into carotid arteries or arteries in the lower extremities as well, if we have a highly stenotic lesion, post that stenosis, we have a drop in pressure and you get post-stenotic dilatation. So we can have that with, severe aortic stenosis. We have a stenotic aortic valve. So post-stenosis would be in that sinuses of Valsalva. We can wind up with aneurysmal changes as a result of a highly stenotic aortic valve. So other pressure overload states, would be hypertension, systemic hypertension, coarctation, volume overload states could be someone that potentially has, fluid overload. So if they have fluid overload, or if say they have renal disease, can put them in a high volume state, renal disease. Liver disease. Can also put them in a high volume state. So the likelihood of rupture is directly related to the degree of dilatation. So likelihood of rupture depends on degree of dilatation. So 5.5 centimeters is considered an indication for surgery. A couple more points. So when we're talking about descending aortic aneurysm, it frequently coexists with substantial atherosclerotic involvement, which can include protruding and mobile components, as well as laminar thrombus. So descending thoracic aneurysm is usually seen with substantial atherosclerotic plaque. And potentially mural thrombus. I'm sorry, laminar thrombus, laminar thrombus. All right, so our good old friend Marfan syndrome, seems like we can answer Marfan syndrome for most of our registry questions, but Marfan syndrome. We know this is an inheritable connective tissue disorder. Inherited. Um, Connective tissue disorder. Associated. Cardiac abnormalities. Which include dilatation of the ascending aorta, as well as mitral valve prolapse. Ascending aorta. And MVP, mitral valve prolapse. So due to that dilatation of the ascending aorta, patients may have aortic insufficiency. AI due to dilatation of aorta. So the reason for that is as we get dilatation, of our proximal ascending aorta, as well as the sinuses of Valsalva, it also starts to pull apart the annulus and separate the annulus, so you don't get proper coaptation of the aortic valve leaflets, and you wind up with regurgitation as a result of that dilatation. So dilatation of that sinotubular junction results in aortic insufficiency. So dilatation can be mild to severe for Marfan syndrome. Dilatation is mild to severe. And we have a sinus of Valsalva aneurysm. So sinus of Valsalva aneurysms most often arise from the right sinus. So often rise. Right sinus. They can vary in size. Right sinus aneurysms can protrude into the right atrium. That doesn't make sense. Oh, no, it does. That's the Winstock syndrome. So I'll show you a picture of that actually. So right sinus aneurysm. Can protrude into RA, right atrium. And it'll look like a mobile circular structure. So this will look like a mobile circular structure. And this is called a windstock. Structure. So I actually uploaded a picture of this.
Does that say they'll look amobile? Like,
Look, yeah.
forget
like
that.
Yeah.
Okay.
Will look like a mobile, like
Oh,
a
got you.
mobile circular structure. More. Am I sharing it right? Kind of.
Yep.
Yeah, so this is a right sinus valsalva aneurysm. So you see this large structure here. This is more protruding into the pulmonary artery. Let me see if I can find one that extends into the RA. All right.
Is it still called Winstock when it's like in the RVOT?
Yes, yeah. Yeah, that just refers to like the appearance of it, this like this cystic structure. Let me see.
Okay.
I think this is that's just an aorta. Yeah, I'll see if I can find it on one map. So a non-coronary sinus aneurysm can dissect inferiorly into the IVS. So sinus valsalva aneurysms most often are the right sinus. A non-coronary sinus aneurysm can dissect inferiorly into the IVS, intraventricular septum. Non-coronary aneurysm inferiorly into IVS. That's where it is seen as a cystic structure, where it is seen as a cystic structure. So a major complication of sinus of valgus aneurysm is rupture. So a major complication is rupture. Complication is rupture. And most common location of the right sinus of valsalva rupture is into the right atrium. Most common site rupture is into right atria. Results in immediate elevation of right heart pressure, jugular venous distension, and a continuous murmur. So results immediate elevation right heart pressure, venous distension, so jugular venous distension, jugular venous distension, and a continuous murmur. Continuous. So other complications of a sinus valsalva aneurysm include distortion of the normal anatomy, which results in a poor coaptation of the aortic valve leaflets, resulting in insufficiency. Causes normal abnormal shape. Sinus, which prevents valve leaflets from overlapping properly. Which leads to AI. So rarely the aneurysm fills with thrombus and mimics an intracardiac mass. Exceptionally rare is a fibrosa aneurysm. So the aneurysm forms in the fibrous skeleton of the heart and communicates with one of the Valsalva sinuses via a narrow neck. Put that down. Very rare, very rare. We have something called the fibrosa aneurysm. Fibrosa aneurysm. This is aneurysm. Forms in the fibrous skeleton. Of heart and communicates with one of the sinuses of Valsalva via a narrow neck. Aneurysm forms in the fibrous skeleton of heart. With one of sinuses this is frequently seen as a cystic space between the aorta and the left atrium. Cystic space. Between aorta and LA and left it LA, yeah. Between aorta, and LA. All right, so aortic dissection now. So the annual incidences of aortic dissection are between 10 and 30 per million. So incidence. Between 10 and 30 million.
That seems like a lot. Is that like a lot?
30 per million?
Like not a lot, just kidding.
Not
I
a lot.
thought it was like 30 million per year. And I was
No.
like, wait.
No, it's not that particularly common, and it really drives me crazy because I worked in 2 teaching hospitals, and these young emergency room residents always thought everyone had an aortic dissection. Anyone like any sort of chest pain or indigestion or, oh, it's got to be an aortic dissection.
They
Like,
just wanted to see one.
yeah, it's like it ridiculous, but that's a whole nother topic. So,
But it probably it caused like a sudden death. I mean, like
yeah, I mean, it results in a sudden severe onset of chest pain and or back pain. So yeah, results in sudden severe chest pain / back pain. And if you think about it, that later layer or that layer of vessel wall is being torn apart and pulled apart. So imagine how painful that, really is. So
I got to see one at Riddle, but the Nicole was like, I'm not really worried about it because it's been there. Like she said it was in the last echo he got.
okay, that's cool. So aortic dissection, intramural hematoma, and atherosclerotic plaque rupture and aneurysm rupture all have similar clinical presentations. And that is referred to as acute aortic syndrome. So dissection usually occurs in the setting of aortic dilatation. So dissection usually occurs setting dilatation. So aortic dimensions of 5 centimeters or more is a more definite risk factor for dissection. Over centimeters. Is a definite risk factor for dissection. Dilatation of 5 centimeters. Is a risk factor. For dissection. And aortic dissection can occur anywhere along its length. So can occur anywhere. So classic dissection. So classic dissection consists of a tear in the intimal layer into the medial layer, allowing blood flow communication between the pressurized lumen and the medial layer of the vessel. So classic dissection. dissection. So it consists hair, intimal layer, hair in intimal layer into medial layer, and allows for blood flow communication between pressurized lumen and the medial layer. Between communication between lumen and medial layer.
But then is it the process how the pseudoaneurysm form in vessels? Like one layer of the vessel is torn and then this pseudoaneurysm formed?
Pseudoaneurysms are a little bit different. Typically, a pseudoaneurysm will be due to a complete hole in that vessel. So with the pseudoaneurysm, you've broken all three layers of the vessel already, and you have blood leaking out. And a pseudoaneurysm is essentially the body encapsulating that bleed and preventing it from spreading all over. So the body is going to kind of try to trap and encapsulate that bleed, and you'll get what looks like your hematoma when you're imaging it, except it'll be an actively bleeding hematoma. So this is, there we go. So this is more of a pseudoaneurysm. You have rupture of all the layers of the vessel. Blood flow is leaking out, coming into the body or whatever space it is in, and collecting, and it forms a large hematoma or a collection of blood. And the body's kind of encapsulating and keeping it there, trying not to let it spread everywhere. So blood flow is going in that hematoma, circling around, coming back out that neck. So blood flow is coming up the neck, going in there, swirling around, coming back out the neck. So that's why when you Doppler this neck, you get that bidirectional flow. So a pseudoaneurysm is different from an actual dissection. Aneurysmal vessels can increase your likelihood of dissection because the vessel now is being stretched and put under stress. So those layers are under more stress. So if we do get a little kind of loose. I don't know. Can you guys see the colors kind of? So this blue is going to be our medial layer. That's our tunica media. This orange would be our adventitia, the outer layer. So this green here would be our intimal layer, inner layer. So we're getting a separation of that intimal layer from the medial layer. And now blood flow is able to get in between those two layers. So if we have, blood flow going in this direction, to say, blood flow now is able to enter into that, what's called the false lumen, that channel.
Mhm.
And when you Doppler, you can, particularly when we're doing carotids, when we're Dopplering and looking for a dissection with carotids, it's much easier to see a dissection on a carotid just because it's so much more superficial and we're much closer. It's harder on ultrasound, on echo. But granted, the vessels are bigger on echo, so you could potentially see it as well, or you are going to see it as well. But when you Doppler in the false lumen, depending on where you are, you could see a reversal. So that flow is going to come into that false lumen, hit where it's still kind of attached and reverse back. So you'll get some bidirectional flow if you're Dopplering that false lumen. Whereas in the true lumen, you'll get your continuous forward flow. So you can tell the difference between your false lumen and your true lumen. So this is your true lumen. This is going to be your false lumen up here, false. And you can imagine that the dissection can only get worse unless they really do something about it, like either try and do a surgical intervention or stent. You continue to get blood flow pushing against that intimal layer, and it could continue to, tear and separate. So that's when controlling blood pressure, becomes real critical. Trying to lower blood volume as well, put less stress on that vessel. And you could potentially see, that intimal flap in the middle of the vessel, that bright echogenic line. But we can also wind up now with thrombus formation within that false lumen. So we can get stasis of blood in here, thrombus formation. And now you also run the risk of developing aneurysm too, along that area of dissection as well, because that vessel wall is weaker. So we have two classification methods. We have our Stanford, so classification. Methods. Dissection. And the Stanford. And we have the DeBakey. So Stanford is broken up into A and B. We have A and B. DeBakey, we have 1, 2, three. All right, so I'll do a DeBakey type 1. So DeBakey type 1 is going to involve the ascending, the arch, and the descending. Put it over here. Ascending, arch, and descending. So that's just going to be the ascending. Big 2, just be ascending aorta. And DeBakey 3 is descending aorta. So maybe for the boards, remember that type 1 is the worst, the most severe. And the reason being is because it also includes the aortic arch. So if we're getting dissection that involves the aortic arch, we then have issues with our vessels as well. We can have a potentially isolated just aortic arch dissection. That would be its own classification. So in terms of Stanford classifications, so the Stanford, Stanford. Okay. So that could be ascending, arch, descending. So Stanford A could be just ascending, could be ascending an arch, and ascending arch and descending. Stanford B is just descending. Stanford B, only descending.
So then how do we differentiate between DeBakey and Stanford if they pretty much
it-
same?
Well, there's two different classification methods. So like you won't be asked to differentiate between the two of them. Certain hospitals will use a Stanford
Okay.
method for, classifying it. Some patients, some hospitals will use a DeBakey method.
Mhm.
It's just two different methods that you might encounter. I remember actually, I went portable just after, COVID was winding down and we're getting back to normal and they were opening back up for heart surgeries at one of my hospitals, and they were starting to get the cardiac surgery patients. And the nurse was like so excited. She was prepping her room. She's like, "Yeah, I got a type A dissection coming in." Woo! Like, because they were so tired of just dealing with COVID all day long. They turned all these thoracic care nurses into COVID nurses, and they were just tired of dealing with that. So when they got back to what they were normally doing, they were so excited. So I know that one hospital used the Stanford method. All right, so with dissection, so patients with ascending aorta dissection have a greater risk of rupture. So patients with ascending dissection have higher risk of rupture. High risk of rupture, pericardial effusion. Effusion. AI, aortic insufficiency. And coronary involvement. Ascending aorta dissections are a surgical emergency. They are a surgical emergency.
Can you scoot the camera like a little more? Perfect.
So patients with an ascending aorta dissection have increased risk of rupture, pericardial effusion, aortic insufficiency, and coronary artery involvement. They are a surgical emergency. So these types of dissections are a surgical emergency. A dissection isolated to the descending aorta can be managed medically unless complications occur.
It's a medical or a surgical emergency when it's in the ascending aorta.
Ascending or surgical emergency when,
Oh, okay.
yeah, it's like when ascending aorta is involved. So a picture of our ascending aorta over here. So if we have a dissection that's, potentially tearing apart that layer that involves the ascending aorta and goes into the sinuses. So if we have our coronary arteries, coming off by the sinuses, that dissection could potentially interfere with blood flow into the coronary arteries. The dissection will also misshape the valsalva, which will prevent the valve leaflets from coming together properly. So you can get AI, so that's your AI. And that dissection could potentially protrude through the aortic valve into the left ventricle if it's severe enough. If that layer is coming off and tearing off, it can then kind of protrude through that valve opening and lead to severe AI. So that's why these are real medical emergencies. So if that layer is coming off, it could potentially block blood flow from getting to the coronary arteries properly. So that's why it's, a real cardiac emergency or surgical emergency, these ascending aortic dissections. All right, so true lumen versus false lumen. True lumen, false. True will expand with systole. True lumen will have a circular or oval shape. Circular or oval shape. True lumen is usually the smaller of the two. Smaller. Two. And this is particularly true of descending aortic dissections, particularly descending aortic dissection. So false lumen, false is typically filled with smoke. False filled with smoke. So we see our spontaneous echo contrast. So often the shearing of the intimal flap results in a small fibrinous tags of tissue seen in the false lumen. So as it's ripping off, sometimes we see little fibrous strands or little fibrous tags of tissue in the false lumen. So fibrous. Tags. Strands. Seen in false lumen. Fibrous tags or strands are seen in false lumen. All right, so now we also have something called an intramural hematoma. So this is a variant of an acute aortic dissection. So this is hematoma. Again, anytime we see the prefix hema, we think blood. This is a variant of acute aortic dissection. So this is a hemorrhage in the medial layer. Medial layer. Of aorta. Which may progress both circumferentially and longitudinally. Which may progress Sclerotum. Eventually. And longitudinally. So this hematoma does not rupture into lumen. It's not rupture. into lumen. And it's between the media and the true lumen. It's not rupture into lumen and located between media and true lumen. So with this, the signs and symptoms are identical to that of an acute aortic dissection. And a TEE examination, will show no communication point between the flow. And there is no flow within the hematoma. But no flow within hematoma, so it's no flow in hematoma. TEE will show no connection point. With true lumen. So we can have a hematoma versus an erythema. Hematoma versus atheroma. Atheroma. There we go. Atheroma will usually have intimal thickening as well as calcifications within the wall. So that's how we can differentiate the two. So atheroma will have intimal thickening. Calcifications. Calcs. Wall. Parenchymal thickening and calcifications within wall. So the use of echo following surgical repair. So the goal of surgery is to prevent dissection from spreading any further. Goal of surgery is to prevent further spread. Dissection. And this often includes a prosthetic aortic graft and sometimes a prosthetic valve. This includes use of prosthetic aortic graft and sometimes aortic valve. So prosthetic aortic graft and sometimes also prosthetic aortic valve. The reason for that being that they may potentially have to put in a new valve as well as if we have that extension all the way down, into that annulus. And if it protrudes, into the valve as well, it could affect that valve. So they'll stent that entire area with a prosthetic graft. And they'll have to put in a new valve within that graft as well. So when they put in that synthetic graft, to repair the aneurysm, depending on how far down it goes, they may need to replace the valve as well. And they will actually resect the coronary arteries and sew them into the aortic graft. So they'll remove the coronary arteries, which are typically, attached, to the sinuses at the level of the sinuses. So they'll resect the coronary arteries and then actually physically attach them onto the graft. So that way we're not disturbing coronary artery blood supply to the heart. So over here, coronary arteries are resected and sewn onto graft. Arteries are resected and sewn onto graft. And again, we also have to, Assess LV function post-surgery to ensure that, the heart's getting good blood supply. And false lumen frequently persists after surgery, especially in the descending thoracic aorta. False lumen persists after surgery. Particularly in descending aorta dissection, particularly descending aorta dissection. And can resolve over time. And resolve over time. Here. Aortic. Atheroma. So atherosclerosis of the aorta is frequently seen during TEE. It's much more common in older patients or in patients that have a history of smoking, hypertension, and elevated cholesterol. So more common. Patients. With hypertension, smoking, and high cholesterol.
Dan, can you raise it up a little bit?
Oh, sorry.
Thank you.
Again, this is seen with TEE. More common in descending aorta. This is atherosclerotic plaque, a form of atherosclerotic plaque that's more common in patients with hypertension, smoking, high cholesterol. We typically don't see them until we do a TEE. And usually the reason we're doing a TEE is we're suspecting, embolus or thrombus. So we're going in doing this TEE, assessing for thrombus, and then we discover these aortic atheroma. They're more common in the descending aorta. So they can be characterized as a symmetric and crescent. So it creates a smooth heterogeneous crescent filling a portion of the aortic lumen. Seen as a symmetric crescent. Crescentic. I never heard that word. Crescentic. Crescent. Crescentic. A symmetric and crescentic appears to create a smooth, homogeneous crescent filling portion of the aortic lumen. Let's see if we can find a good picture of that. Creates smooth crescent filling portion of the aortic lumen. And can be a source of embolic events. And the source embolus. Share screen. There we go. There we go. Here's an example, crescent shaped, smooth. Like we said, involves intimal thickening. You typically see some calcifications too, so this one's calcified. This was a form of atherosclerotic plaque. So some complications from atherosclerosis include aneurysm formation, another complication would be aneurysm formation, complications. Aneurysm formation. And penetrating ulcer of the aorta. So let's have coarctation. Aorta. So we've seen suprasternal notch view. So most common location is proximal to innominate. So the most likely spot for a coarctation is going to be just at the beginning of our arch. So we'll get our coarctation. It's usually the proximal to the innominate. So this results in decreased blood flow throughout the body. So if you think about it, if you're getting that narrowing before all your great vessels, you're going to wind up with lower blood pressures in both arms. You're going to wind up with reduced blood flow going to the brain. So symptoms are very apparent early on with the coarctation. Depending on where exactly that coarctation is, the patient will have different symptoms. So if you get a coarctation that's, between, say, the innominate and the left common carotid, the patient's right-sided blood pressures will be normal. The patient's left-sided blood pressures are going to be reduced, diminished. So they'll also have potential symptoms. You'll see, if you're imaging the carotid arteries, you'll see reduced flow within, the common carotid, ICA, ECA, whereas the right side velocities would appear normal. As we know, coarctation is also increases our afterload. So we're increasing, it's a pressure overload, increasing pressures on that heart.
Can you shift the camera again,
Oh,
just to the
sorry.
right?
Sorry. Come here, buddy. So most common location is proximal to the innominate artery. So at the beginning of that arch, and that will result in decreased blood flow throughout the body. So you'll have lower brachial pressures bilaterally. You'll have reduced flow within your carotid arteries. These patients will exhibit symptoms early on, so they're able to find this quite early. Depending on the severity of the coarctation, they could potentially have cyanotic extremities. It could potentially be a big deal. And then you also have to consider when you're like sitting for your boards and your registries, at what level exactly is the coarctation. So if the coarctation, say, is past, the arch completely, and you're getting a coarctation in the descending aorta, your brachial pressures would be normal. But it could then affect things like, renal blood flow. So you could have, issues with the kidneys. Blood flow getting to the rest of the organs, mesenteric ischemia. So there's other things that could potentially be the issue. Or if you're, kind of switching gears and thinking vascular, if a coarctation is, say in the descending thoracic aorta, you'd have reduced blood flow getting to the lower extremities. So your PVR waveforms could look, a little funky. You'd have reduced pressures in your legs. So you have low pressures throughout, all the legs. So that could potentially be a symptom. I think one of the last couple of things is aortic pseudoaneurysm, which we kind of discussed a little bit before. So a pseudoaneurysm is a contained rupture of the aorta. So aortic pseudo aneurysm as a contained rupture of aorta. So again, we have that aneurysmal sac that's connected by a neck. So can occur due to spontaneous rupture of aorta. Can occur due to spontaneous rupture of aorta. As part of the dissection. As a result of trauma. Or from iatrogenic injury. So what that is injury from a procedure that was done intentionally or something that, was done in the hospital. Iatrogenic injury. So we can also have something called aortic transection. And this is a catastrophic result of blunt trauma to the chest. So this is a type of injury that could be sustained in, say, like an automobile accident or a traumatic injury to the chest. And this is a partial or complete transection of the descending thoracic aorta, usually at the level of the ligamentum arteriosum. So this is aortic transection. aortic transection. Caused by blood trauma to chest. Blood trauma to chest. So like the automobile accident, so MVA, motor vehicle accident, like a motor vehicle accident. So a partial or complete transection of the descending thoracic aorta, partial or complete transection descending aorta. So a complete transection is a nearly instantaneous fatal event. Partial transection may allow for survival. So fatal. Complete. Think of it, someone gets hit in the chest really hard, and the aorta suddenly completely separates that descending aorta, and they just bleed out. So sometimes limited trauma can result in the formation of thrombus within the medial space or in the lumen of the aorta. Sometimes trauma may cause thrombus in the medial space or lumen of the aorta. So if this is noted in a young patient following trauma, thrombus should be considered over an atheroma. Aortic trauma. Can also lead to acute rupture of the sinus of Valsalva. So aortic trauma can also lead rupture sinus of Valsalva, particularly right Sinus. Sinus. Usually. And if it's the right sinus, it'll rupture into the right atria. Right sinus. So if we do say aortic thrombus, aortic thrombus is more common in the proximal descending thoracic aorta. Almost done. Aortic thrombus. Common. Possible descending. And is often associated with embolus. To peripherals. So if it's in the descending aorta, embolus to the peripherals, that's going to wind up at the toes. So in the clinical setting, these would be the patients that you'd worry about that have a blue toe. Like it's usually like one toe is blue and the rest look fine, and it's like very strange. It's like these thrombus are highly mobile, echodense masses within the lumen or the aorta. You can also put they're highly mobile. Mobile. Echogenic. So the last thing is going to be Takayasu arteritis. Takayasu. Let's spell this right. Takayasu arteritis. So this is an inflammatory disease of the aorta and proximal branches. Inflammatory disease. Aorta. And branches. Occurs in patients that are younger than 40. And patients younger. Forty. So results in irregular intimal thickening and the accumulation of inflammatory tissue in the proximal aorta and its connections of the major branches, including the coronary arteries. Results. Marked. Irregular. Intimal thickening. Accumulation of inflammatory tissue. Inflammatory tissue. Inflammatory tissue. Oh, two ends. Inflammatory tissue. In the proximal aorta and its connection with the branches in proximal aorta. And branch connections. So it's going to affect that proximal aorta as well as the branches where the branches connect. So it's going to also affect those connections as well. And also to remember that it's going to also affect the coronary arteries as well. It will invade the coronary arteries with the thickened intimal layer with inflammatory tissues. Aortic branches. And coronary arteries. And it has a similar appearance to atherosclerotic disease. Similar appearance. To atherosclerotic disease. So it's going to affect the aorta as well as the openings into those proximal vessels, the proximal branches. So it's going to affect the aorta and kind of go into the beginning portion of those proximal branches. So it's also going to affect the coronary arteries as well. And it's an inflammatory disease that causes thickening of the intimal layer, which looks irregular. And it occurs in patients younger than 40. That could be your giveaway on a registry question. Takayasu arteritis. I'm like LeBron James.
Good job, Dan.
I know. Crazy. Big ass pieces of chalk too. They're really hard to write with.
You have to watch those shorts every day.
Yeah, right.
I was that too.
Terrible. Oh, this PowerPoint didn't have too much on coarctation in her slides, so I was gonna see what else I could find because coarctation is pretty important, especially if you want to go into pediatric echo. So I'm gonna upload some more slides and pictures for coarctation, see if I can find a little more information. It's not too bad. I don't know, any questions about the aorta and aneurysms or dissection or anything?
So we don't have any more quizzes left, or do we still have one more?
Still have one more, which is like disease of the aorta and the tumors, I believe.
Oh, okay. The tumors and the masses.
Супчик еще там остался. Супчик, который я приносила. Да.
Ah,
More his face.
wait. So it would
Always in
be
trouble.
like the tumors that we did like last week. Okay, and then aorta. So is this quiz going to be next week or the week after?
No, it's on schedule. I think
it's scheduled next week.
next week. Right?
Yeah.
Next week. Okay.
No, it's the 23rd.
Okay, so week after.
Yeah, week after. You got a week.
So are we learning more things next week that are going to be on the quiz too?
I'll pull it up. I don't think so. No, I think it's just those. Next week they had on the schedule talking about endocarditis. So. I
Oh,
don't-
okay.
Yeah, I don't think that was on the quiz.
Okay.
Just double check. I don't know.
We're almost done, guys. Ish.
Oh,
And then we do it all over again.
into- Did you understand my notes that I sent you? Did you?
I
even-
did.
Like
I also like rewatched the lecture too, so that was helpful too.
I write my notes kind of weird.
I do too, honestly. I feel like I bounce around.
Mm-hmm.
Yeah, it does look like, let's see. endocarditis. So it's myxomas, tumors, diseases of the aorta, and endocarditis.
Okay, so it will be on there.
Next
All
week,
right.
yeah.
Fine.
Fine. Yeah, but the final I was on here is super easy. I'll be honest.
Okay.
I like the one that's that she gave me to give you guys.
Is that the one you're giving us?
Yeah, yes.
Okay.
Guys will have no problem. Promise.
So the quiz is on 23rd, right?
Yep.
Yeah.
It's gonna be
All right.
the aortic disease, the tumors and masses, and endocarditis,
Cool.
which we've already touched on endocarditis a little bit. So
Yeah, I
guess
thought
we'll
we
just go a little
did.
bit more. Yeah, we did a little bit on endocarditis, so it's not gonna be bad.
We're not doing a review for the final.
No, Dan hates us. It's like, wouldn't we do that on the 23rd?
We-
Yeah.
sure. Yeah.
He's like, it's too easy. You guys don't need a review.
Yeah.
I'll need a
It's
review.
like, forget review.
That's my superstars.
We'll see when it comes time to go to
Right.
boards.
Boards, I know. Don't even think about boards yet. I'm telling you, once you start doing your clinicals every day, it's all gonna fall into place and you'll be like, oh, that makes sense. Oh. And you'll
Yeah.
start seeing more things and
I think so.
Yeah, we're
hope
just like a babies that listening, and then all of a sudden start to talk.
Yeah.
Yeah, right, right.
yeah, it really is. And you know, we have resources here too. I mean, if you ever want to get a head start and reviewing, can't hurt. Like there's tons of books and videos. Like we have a whole DVD series that like for board reviews for Echo. So I mean, you could put a disc in and do one chapter at a time and yeah, you'll be ready. I mean, they're past.
Yeah.
So,
I guess we have another year to worry about that.
yeah.
Yeah, exactly. Cool.
So
Do
enjoy
you
it.
know when we're gonna be able to register for classes? I mean, I know we technically can, but Kathy told us not to.
Yeah, there was an issue with the master schedule. Like we submitted it and then registrar royally messed it up. Apparently they put Lily and Donna back on as professors. They took her out of retirement and I don't know.
Okay.
But
Cool.
everyone's seats have been reserved. So it's not like you're gonna like, lose out. Let me ask her. I'll see if it's been finalized. Oh, hey. I hear it all.
I hear
Want to tell
all
them
the-
the schedule?
Yeah.
Yeah, so really, Morgan, there's no rush because all those classes are like held for you. I know that it's all part of like what's like behind the scenes. It's still just like a little bit not perfect. So we can kind of like run through what classes you have each day.
Yeah, that would be awesome.
Sure.
I have to go back to the
Sure.
meeting. Thanks.
Gotta go back. Nope. Wrong one.
Then maybe you can stop recording because this video is gonna be
Yeah, that's
long.
exactly what I'm trying to do here. Stop recording.